Hi, my name is Mike Datto. I'm a pathologist at Duke University Medical Center, and this is a slide from the USCAP virtual slide box. It is a colon resection specimen. To orient you a little bit, we have the internal luminal surface of the colon, the external of the colon. The normal colon, is composed of different distinct layers. We have a small amount of normal colon over here. We have the mucosa, the submucosa, the muscularis propria, and subserosal fat. So to remind you what normal colonic mucosa looks like, it is composed of glands. The glands are test tube shaped. In this particular section, the glands are cut in cross section and look more like circles than test tubes, but they are test tube shaped. The glands are composed of epithelial cells. The epithelial cells are specialized colonic epithelial cells. Specifically, we have a whole lot of goblet cells here, which contain abundant mucin. The nuclei of these cells are small. They're small compared to the amount of cytoplasm in the cells. We call that the nuclear to cytoplasmic ratio, and the ratio here is low. Around the glands is the lamina propria. The lamina propria contains various inflammatory cells, some plasma cells, and lymphocytes. In this section, we also have a germinal center composed of B cells and T cells, not necessarily in itself anything particularly concerning. So we have normal colonic epithelium composed of the mucosa with specialized colonic epithelium. Now, adjacent to this, we have something very different. When we put the two side by side, you can see that the nuclei in this region are much larger than the nuclei over here. The nuclear to cytoplasmic ratio is much higher in these glands than over here. We also have a complete loss of the architecture. Rather than seeing normal test tube shaped glands, we have these sheets of abnormal cells with high NC ratio, large nuclei. This is a classic picture of adenocarcinoma. So the diagnosis itself is not terribly difficult, although there are a lot of things that we have to look at in order to provide all the information necessary for the care of this patient. One of the things we have to do is stage the tumor. The staging of colonic adenocarcinomas follows TMN staging system, like many tumors. The T in the case of colonic adenocarcinoma is a little bit different than other carcinomas, based on the fact that it's not the size of the tumor that is important, but the depth of invasion of the tumor. The tumor can be in situ, meaning that it does not cross the muscularis mucosa, the thin wisp of muscularis that's at the base, or the thin wisp of muscle that's at the base of the colonic glands. A T1 would be a tumor that crosses the muscularis mucosa, that crosses the muscularis mucosa and goes into the submucosa. We have a little bit of neoplastic cells here, it looks like, from next door, maybe. But T1 would be crossing into the submucosa. T2 would be a tumor that extends into the muscularis propria, the thick muscle layer that surrounds the colon. A T3 would be a tumor that penetrates completely through the muscularis propria into the subserosa, the subserosal fat. This region down in here, so through the muscularis propria into the subserosa, and a T4 would be a direct extension into other organs or structures. So staging of the tumor is important. Also, in these samples, we look at the lymph node status. N0 would be no lymph node involvement. N1 would be 1 to 3 lymph nodes involved, and N1 would be 1 to 3 lymph nodes involved, and N2 would be 4 or more lymph nodes involved. And of course, part of the clinical staging is the M stage, which is distant metastasis or not. which are difficult to evaluate when all you have is a colon resection to look at. There are some other things that we can look at in these tumors. One feature is lymphovascular invasion, and there is abundant lymphovascular invasion in this tumor. Even from really high power, you can kind of pick it up, the lymphovascular invasion, because you can see them as sort of floating islands of tumor within vascular structures. They have a very different appearance than adjacent tumor. So we have abundant lymphovascular invasion here. We have our endothelial cells, if this is vascular, or could be lymphatic cells, these small flat cells, and then we have these masses of tumors within, masses of neoplastic cells within these lymphovascular structures. So we have lymphovascular invasion here. So there are also a number of molecular things that we look at in these tumors. I'm a molecular pathologist by training and trade, so forgive my description of the histology, but I'm a molecular pathologist, and there are a variety of different ancillary studies that we can do to help in the care of these patients. In a younger patient, or in a patient with a poorly differentiated adenocarcinoma of the type that we see here, we can consider the diagnosis of hereditary non-polyposis colon cancer. Now, there are a couple of histologic features that lead us in that direction. One is the poor differentiation. We see sheets of tumor cells rather than distinct glands. Another feature of this tumor, which is suggestive of HMPCC, is this dense inflammatory infiltrate surrounding the tumor. We call that a Crohn's-like inflammatory infiltrate. If a tumor is right-sided rather than on the left side of the colon, that's suggestive of hereditary non-polyposis colon cancer. Tumors in a young patient are suggestive of hereditary non-polyposis colon cancer. So there are a number of studies that we can do to help determine whether or not this patient has an inherited tumor syndrome. One of those studies is microsatellite instability studies, where we look at normal mucosa and adenomatous or neoplastic mucosa, and determine whether or not microsatellites have become unstable. So microsatellites are small repeat sequences in the genome. In tumors from patients with hereditary non-polyposis colon cancer, there is a loss of mismatch repair genes. This loss of mismatch repair leads to instability of microsatellites, so they grow or shrink in size, mostly shrink in size. So we can look through simple PCR-based techniques for microsatellite instability. We can also do immunohistochemical staining directly for these mismatch repair proteins to see if their expression is lost. So many of these cases will get immunohistochemical staining for MLH1, MSH2, MSH6, and PMS2. We see characteristic loss patterns in patients with HMPCC. There's some other ancillary testing we do in patients with colon cancer testing. We test for KRAS mutations, for determining efficacy of EGFR-based therapies like cetuximab. But that is about it. So a poorly differentiated colon cancer, the histologic characteristics of dense inflammatory infiltrate and poor differentiation are suggestive of HMPCC. The types of ancillary studies we might do are microsatellite instability testing by PCR, or the evaluation of mismatch repair protein expression by immunohistochemistry. MLH1, MSH2, MSH6, and PMS2 are the four proteins that we look at. Following up from that, we can look at things like MLH1 promoter methylation or BRAF mutation status, to determine whether or not these cancers are more likely from an acquired tumor syndrome, HMPCC specifically, versus sporadic tumors. And that's it. Thank you.